I'm Bianca Weinstock-Guttman, Professor of Neurology at the Jacobs School of Medicine and Biomedical Sciences, and we'll talk today about the role of S1P receptor agonists in MS, strategies for disease management. S1P receptors have been proposed as a therapeutic target for various diseases due to their involvement in regulation of lymphocyte trafficking, brain and cardiac function, vascular permeability, vascular and bronchial tone. S1P receptor modulators were first developed to prevent rejection by immune system following renal transplantation, but FDA approved today are only for multiple sclerosis and ulcerative colitis. The primary mechanism of action on S1P receptor modulators in MS is through binding S1P receptor subtype 1 on lymphocytes, resulting in internalization of the receptor and loss of responsiveness to the S1P gradient that drives lymphocytes egress from lymph nodes. The reduction in circulating lymphocytes, presumably, limits inflammatory cell migration into the CNS. The S1P receptor 5 may benefit oligodendrocyte survival. 4 S1P receptor modulators, fingolimod, siponimod, ozanimod, and ponesimod, have regulatory approval for MS. S1P modulators have complex action on receptors, in some cases acting both as agonists with functional antagonism and as traditional agonists in other cases. Subsequently developed S1P receptor modulators are more specific with the goal of preventing effectiveness while mitigating some of the adverse effects, cardiac and vascular. The improved pharmacodynamic and subtype specificity for S1P receptor 1 and 5 may also contribute to improved bioavailability and potentially greater CNS effects compared with fingolimod. Fingolimod, a product that requires phosphorylation, has broad receptor affinity, S1P receptor 1, 3, 4, and 5. Ozanimod and siponimod are selective modulator S1P receptor 1 and 5, and ponesimod is specific for S1P receptor 1. All S1P receptor modulators are thought to have a similar effect on lymphocytes, although their different half-life time is important when considering adherence and discontinuation therapy. Phase 3 clinical trials have been completed for fingolimod, ozanimod, and ponesimod, evaluating efficacy in relapsing remitting MS. All studies found a significant reduction in the primary outcome, annual relapse rate over 12 to 24 months, compared with placebo, interferon beta-1a, or teriflunomide. There was also significant benefit on MRI markers, including gadolinium-enhancing lesion, T2 lesion, as well as measures of tissue damages, T2 hyperintensive, T1 hyperintensive lesions, brain volume loss, and cortical matter and thalamic volume loss. There were variable changes in worsening of disability as measured by EDSS and MSFC, showing significant benefit in one fingolimod trial than siponimod while compared with placebo, but not reaching significance in the other studies that were evaluated against active comparators, interferon beta and teriflunomide. All S1P modulators are today approved for clinical adolescent syndrome, relapsing remitting, and secondary progressive. However, only siponimod has so far demonstrated efficacy in active SPMS, contrasting with the absence of clinical effects with fingolimod in primary progressive MS. Important consideration in the use of S1P receptor modulators in MS is the slowing of heart rate and AV conduction with initial initiation of the therapy. On initiation of therapy, fingolimod acts as an agonist activating S1P receptor, leading to transient bradycardia, delayed atrioventricular conduction, and prolongation of the QT interval. With continued administration, there is downregulation of S1P receptor and resolution of the cardiac effect. Therefore, for fingolimod, there is a first dose effect required, the so-called FDO, first dose observation, for at least 6 hours for all patients starting this therapy, and they are monitored with pulse and blood pressure hourly, ECG before dosing and at the end of the observation period. However, the benefit of dose up titration, as on ozanimod and siponimod, over the first several days of treatment attenuates the need for initial cardiac effects, and no second or third degree AV block was reported in the phase 3 trials, eliminating the requirement for FDO in the absence of a cardiac history. Additional side effects are considered to be related to vasoconstriction as increased blood pressure, macular edema, and pulmonary dysfunction. Many of the adverse effects observed with fingolimod were thought to be related to broader engagement of S1P receptor, which led to the development of the more selective S1P modulators. Infections were reported in all phase 3 clinical trials, including upper respiratory tract infection or urinary tract infection. One death occurred in the phase 3 trial of fingolimod due to disseminated varicella infection, leading to the recommendation to check varicella zoster antibodies before initiation. There are also rare cases of progressive multiple cardiac encephalopathy due to the reactivation of JC virus and cryptococcal meningitis. There's also an increased risk for skin malignancy, especially basal cell carcinoma. So the recommendation for S1P use, there are contraindication in the prescribed S1P modulator, including primary history of several cardiovascular conditions, MI, TIA, stroke in the last 6 months, unstable angina, as well as six-sinus syndrome, QT interval more than 500, and cardiac arrhythmia, as well as severe sleep apnea or MAO use. With siponimod, the majority of patients can initiate treatment without the need for monitoring, whereas FDO is recommended only for patients with sinus bradycardia. With ozanimod, no monitoring and treatment initiation required, but cardiologist consultation is suggested for patients with conduction abnormalities. Differential pharmacokinetic response to siponimod in patients with CYP2, C9, genotypes 1, 3, or 2, 3, required the genotyping of patients for a siponimod, and that's been performed before treatment start, as the genetic changes required a lower dosage of 1 milligram instead of 2 milligrams as for usual patients. Strong CYP2, C8 inhibitors, as GAM5%, are contraindicated and advised to avoid foods containing a large amount of tyramine, as cheese or pickled herring, while taking recommended doses of ozanimod. So in general, baseline and monitoring, we need a blood workup baseline and monitoring with CBC because of the risk of leukopenia and liver function. Evaluating for varicella zoster antibody, if negative, vaccination required before initiating therapy. Ophthalmology evaluation, including OCT, is related to risk for macular edema at baseline and any time there is change in vision. And dermatology yearly evaluation for the risk of cutaneous malignancy as basal cell carcinoma, squamous cell, or melanoma. Thank you very much for listening.